2022, Danny, welcome back for the New Year's edition of Cancer Specialist Medical Minute.
Welcome back, everyone. 2022. How does it feel, Rick?
I feel older, more gray hair, tired, haggard, weathered.
You look it, too.
Yeah.
So
Thanks. Appreciate that.
You can blame it on Omicron, That's what I do.
Yeah, I think this one's on age.
Okay, age. That
Children.
That works. Well, thanks so much for coming back and joining us for another episode of Medical Minute. And I'm reading the outro. Rick, this new year is not starting out good, I tell you.
So for those of you who we don't have video yet up, but Danny is shuffling through papers, trying to find his lines.
I thought I would do something different this year because we've done 19 episodes and not type out the intro clearly.
You know my Ron Burgundy moments here where I read what's in front of me.
You're an actor who needs your lines.
My lines were in front of me, but I do have a good joke for you guys.
And we're ready.
Okay. Sure, Danny.
And this one particular, Brenna will like. What do you call a fake noodle?
A fake noodle?
A fake noodle.
I'm not sure.
An impasta.
You're
knew
right.
she would like
You're
that.
right. Brenna did like it. So nothing really has changed this year so far.
Yeah.
So the topic of this episode you probably saw when you downloaded this is cervical cancer, which is a disease that is thankfully there's been a lot of strides made in the prevention of cervical cancer, and unlike a lot of cancers we've talked about previously on this podcast, this is one that the vast majority of cases can be prevented. So I think it's very important, and it's very one that where information is extremely important to get out to the public.
I think prevention is key. I think in the United States, I think we do a pretty good job of doing regular gynecologic exams and screenings and HPV testing, which we'll get into. But definitely some third world countries are a little bit behind on the preventative screenings we can do for cervical cancer, and you see a little bit higher incidence in certain countries because of that.
Yeah, I think you hear a lot these days about, inequality in this country and social inequality and sort of, different things that go on in different parts of this country. And I think this is a perfect example because unfortunately there's good data showing that really a lot of cervical cancer in this country comes from areas of low socioeconomic status, poor access to healthcare, those type of geographic areas. So it's something that you're absolutely right is extremely, higher incidence in third world countries, but also in parts of this country, there's extremely high incidence that match the rates of third world countries. It's kind of scary. So I think getting information out there is key.
Yeah, I think, one of the things, according to CDC, long-lasting infections with certain types of HPV are the main driver for cervical cancer. It's really the cause of cervical cancer, Rick. And, we screen patients for that. We gynecologists usually take the first step in meeting with patients and doing pap smears and doing the appropriate screening for this. And we do have vaccines for this virus too, which are really effective given at a young age, but just because you're adult doesn't mean you can't get this vaccine. Actually, I think primary care providers are giving it up until age 40 now, I think, in certain cases.
Funny, when I was in medical school or residency, I tried to, because I grew up before.
Come on, Dr. Sugarman. We're recording. Let me put this on pause, Rick. I'm sorry. Go ahead.
So I remember when I was in, I think, medical school or residency, I grew up before the HPV vaccine was available to boys. Mm-hmm. And so I was trying to get it in my 20s, and I kept getting denied because it hadn't been approved. And then finally, it got approved for folks up to, 30s, 40s in age. I think with cervical cancer, the thing, like you said, HPV virus, but just backing up real quick for the audience, HPV stands for human papillomavirus. It's a virus that's very ubiquitous in the population. So a lot of times we, think of, well, how did I get this HPV virus? What did I do to, how did I pick it up? And,
right.
This is just one of those viruses that lives amongst all of us. I think there's, I don't have the study in front of me or the number, but it's something like 90+% of people have HPV colonization at some point in their lives. You know, and so people don't look at it as a stigma if you find out you have this virus, you know, either
Right.
in the head and neck area or in the cervical region. It's something that's very ubiquitous in the population, and so the screening for cervical cancer with Pap smears and HPV testing on those Pap smears applies to everybody, whether you're someone, you know, who's extremely sexually active or not, you know,
Right.
whether you're a smoker or not, whether, you know, you have other medical comorbidities or not. So it applies to everybody.
It applies to everyone. I think, yeah, statistically, it's if you're sexually active, the chances are more likely that you've been exposed to this. And, you know, there are subtypes of the human papillomavirus that are we think the cancer-causing subtypes. And this is what the gynecologists screen for. They can subtype HPV when they do Pap smears. And, you know, not all HPV will show up, and most people won't know they're infected with it, right? That you won't have any skin lesions, and skin lesions I mean genital warts, but you know, you should still undergo the appropriate screening, and you know, that's the way we prevent this cancer. So Rick, you know, should we go over a little bit about the staging of cervical cancer, or how we treat it in clinic?
Yeah. So when a woman gets diagnosed with cervical cancer, you know, historically, radiology, so CT scans, MRIs, were not part of the staging process because, as you mentioned earlier, it's a disease that's, you know, predominantly in lower income countries where maybe those diagnostic scans aren't available. So it used to be a very clinical based scanning, chest X-ray, physical exam, and then they allowed, you know, for kidney ultrasounds to look for hydronephrosis, which is basically swelling of the kidneys that can lead to kidney problems long term that can be from the cancer. But I think in the modern era in the United States, the combination of physical exam, so getting a good pelvic exam to assess the extent of disease, and then imaging, usually with an MRI of the pelvis, which will give us further anatomical information, and then a PET CT scan, which is a CT scan that scans the whole body, looking for signs of cancer, not just in the cervix, but also making sure it's not moved to other organs or other areas of the body, is how we stage it. You know, I don't know if you have anything more to add staging wise.
No, I think that's a good overview for staging. I think just to talk about what is done pre-staging, you know, we have a patient, for example, that had a Pap smear and had some cancerous cells detected on their Pap smear, and then you would proceed with certain imaging, as Rick mentioned, to kind of decide on staging and what the most appropriate treatment would be. There's even the possibility that there's some atypical cells detected during a exam with a gynecologist, and that's treated differently. Usually there's other procedures that are done, and then a surveillance plan afterwards.
Yeah, so when you have an abnormal Pap smear, typically what will happen is the gynecologist will then do a further kind of in-depth look at the cervix. We'll actually go in under magnification and light and sort of examine the cervix and look to see, are there any areas that could be targeted and biopsied. There are different procedures, as you mentioned, leaps and other things that they can kind of cut out portions of the cervix or take a deeper biopsy to get assessment of, is this just atypical cells or is this true cancer? And as you mentioned, if you have atypical cells, it doesn't mean you have cancer, but what it means is you're at a risk of developing it in the future. So you're going to be on a different regimen of more frequent exams, more frequent pelvic exams and looks at the cervix to make sure nothing develops over time.
Right. And that's usually the progression of why the cancer forms, is start out by being exposed to HPV, the cells in the cervix become atypical and then eventually form cancer. And this is over several years, sometimes 10, 20 years. So very important to get your exams. So I don't think we should go into too much detail about treatment. I think that's beyond the scope of this talk. I think we can give a general overview.
Yeah, so I think, basically speaking, very early stage cervical cancer, so cervical cancer that's only in the cervix, not very large, very tiny, is treated surgically, where they remove the cervix and typically the uterus and the surrounding lymph nodes of the area. And that's usually all you need in those situations is just the surgery. For women who are desiring to maybe still have children despite having a diagnosis of cervical cancer, there are certain scenarios where if the cancer is small enough, they can get away with sort of a partial, where they remove the cervix, don't remove the uterus, and sort of can create procedures to allow for fertility to still be a possibility. But in general, unfortunately, in the vast majority of cases, if there's a diagnosis of cervical cancer, usually the entire cervix and uterus is removed at the earlier stages. As the disease becomes more advanced, if it's larger, if it's near into the uterus, if it's into the vagina, if it's into the lymph nodes or other areas of the pelvis, then really radiation becomes the primary treatment for it, usually with chemotherapy as well. And so those are kind of the big picture overviews of very early stage is treated surgically. Pretty much every other stage is treated with a combination of radiation and chemotherapy.
Right. Yeah, usually with chemotherapy, we're giving a weekly regimen with the radiation treatment that you're giving in clinic, Rick. And then advanced cervical cancer, if it has spread outside to different organs in the body or lymph nodes that are more distant away from the pelvis, we treat with certain chemotherapies, sometimes administer immunotherapy to those patients. So there's a variety of options, but I think we're definitely doing a better job catching it early. Earlier you catch it, the better chance of cure, like all cancers. But the screenings for cervical cancer really have saved a lot of patients and really even prevented a lot of cervical cancers, along with the vaccine.
Yeah, and again, I think Brenna gave us some of these stats here, but the 14,000 new cases per year is the most recent estimate from the American Cancer Society. That number has downtrended significantly over the last 3 or 4 decades just from more appropriate screening. And if you actually look at the heat maps of where these diagnoses are, like I said, unfortunately, they're predominantly in lower socioeconomic areas in certain, urban centers where, the access to some of these screening procedures, the access to a gynecologist can sometimes, unfortunately, be limited. So it just reinforces the point of, if you're a woman, make sure you get, your regular pap smears and pelvic exams as recommended by your gynecologist.
The screening recommendations, Rick, have changed slightly to where women who have several negative screenings and test negative for HPV can space out their frequency of exams with gynecologists, and it's changed from every 3 to 5 years in certain individuals once you test negative. So I think the big key is identifying patients that are at risk, screening them appropriately, and if you have a patient who never had a negative pap smear and it tests negative for HPV, once they reach their 30s, you can really push those screenings out to about every 5 years, which I think a lot of patients are happy about not having as frequent exams. I don't know if you had anything to add there.
It's 2022, but you know what it also is?
No, Rick. Can you tell me?
It's January.
It's January.
And January.
It's my birthday month. You know that, Rick?
I do. You've been bugging me about it for a week. You've been bugging me about it. Actually, it's in my calendar.
When is your birthday?
23rd.
Yeah. It's in my calendar.
Coming up.
Hope we can get out on.
Well, we're planning a little golf match. Yeah. Not a match. We'll play together.
We're just having fun. I was like, it's a match? I didn't know. It's so serious.
This is new to me.
Yeah, he doesn't know until he shows up, and then it's...
So other than your birthday,
yes.
January is also Cervical Cancer Awareness Month. I don't know if you were aware.
Not until this episode, Rick, no. But thanks for informing me. I think, that's important. I think raising awareness that patients should really undergo the screenings they need. And
well, I think it's just the take home for this is unlike a lot of the other things we've talk about. This one is almost, in a lot of cases, fully preventable. And as the expression goes, an ounce of prevention is worth a pound of cure, meaning it doesn't take a lot to do these things, these screening procedures, but you can save yourself a whole heck of a lot of heartache on the back end from if you ended up having the diagnosis.
Let me flip my page here, Brenna.
Oh, God.
Flip my page. Now I'm ready for it. Thanks so much for coming back and joining us for another episode of Medical Minute.
If you have any suggestions on things we should talk about, questions you'd like answered, or suggestions for the new year, you can email us at medicalminute@csnf.us.
And make sure you follow us on social media. Search Cancer Specialists of North Florida on Facebook and _CSNF on Twitter and Instagram.
And as always, we appreciate you giving us a few minutes of your time, and we hope you learned something today.
And remember, when it comes to your health, stay informed.
Ask questions and tune in next time.